and we are going to prepare now for your observerships, for your intern year. And so this is, I think, a topic that you should pay attention to. And this is, where does the patients that come to the hospital come from? Where does they come from? Usually you will think, where does they come from? From their homes. Yes, yeah, that's one subtype of patients. The other one is the homeless patients, the ones that live in the streets. That, I don't know, they have a fall, they have a fight, and they end up in the hospital, right? The other one is transfers from a different hospital. Why could a patient be transferred from a different hospital? For example, I went to the hospital that is close to my house, and I had a stroke. But this hospital I went is not a stroke center, and they realized that in my CT angio of the neck there is a large occlusion. So because this hospital that I went to is not a stroke center, they will make arrangements asking around which stroke center that has neurointerventional capacity will be able to receive me. And so this little hospital where I went first will start asking who can take me. When a stroke center that can do the procedure I need accepts me, I get transferred to this hospital. So these are the first easy cases that you will be able to work on your observerships or your internship, to do your HMPs, to do your assessment and plan. The easy ones. These are easy ones. Why? Because usually these are people that you can take or make or get a history from them or from the available documentation that they have. This is the simple, the ones that you probably know by now. But also there are 4 other places that you can receive patients from, and this is the different facilities that are around the hospitals. One of them is I'm going to mention the 4 of them: skilled nursing facilities, subacute care facilities, LTAC or long-term acute care facilities, and custodial care facilities. So let's talk about each of them, because when you present a patient to your attending, you have to say, where is this patient from, if it's from one of these facilities. Why? Because this becomes important. Remember that discharge planning starts when you meet the patient. So if you tell me, if I'm your attending and you tell me this is a 75-year-old male patient who is a chronic resident or a long-term resident of a custodial care facility, or say this is a 75-year-old male patient who is currently living at a local subacute care facility, or at a local skilled nursing facility, or at a local LTAC, after being discharged from a hospital. So it makes a difference. Why? Because I know that what we are doing right now will be continue at these facilities, and the duration of the hospital stay for this patient may not be the same if he is from an LTAC. I may just need to stabilize him to be able to send him to an LTAC. Whereas if a patient is going to custodial care, I need to stabilize him, treat him, improve him, and then send him to custodial care, because custodial cares don't have nurses. So let's talk more about each of these facilities. So the simplest one, the lowest level of care of them is custodial care facilities. Custodial care facilities are facilities that, if you have insurance, your family member, your loved one, above certain age group can be there, live there, and usually there is 1 or 2 nurses for a large amount of patients. These patients are not complicated. These patients don't need any other nursing care that is not for medications. They can receive physical therapy. They can receive wound care there. It's like living in your home, but this facility becomes your home, and there is a nurse. And you get there because you have insurance. But because you're still a person, you still have problems, these persons living at the custodial care can get any disease that anyone else can get. So we usually get patients that come from custodial care, for example, for falls and having a hip fracture. We get them for respiratory symptoms, and maybe it's COVID, and everyone in the facility got COVID. Or when the flu season is flu, a patient that comes with fever, runny nose, and cough. And so the presentation of the patient is, this is a 75-year-old male patient who is a long-term resident at a local custodial care center or facility, who was brought into the emergency department with the chief complaint of fever, shortness of breath for the last 5 days, blah, blah, blah. So lowest level of care, custodial care, no skilled nursing care, only for medications, long-term, and medications only. The second level, the second lowest, will be a skilled nursing facility. So this is one of the most popular that we will use in hospitals, and you will see the abbreviation is SNF, and it sounds as a SNF. We call it a SNF. Let's send this patient to a SNF. I'm going to call a physical therapist. The physical therapist will tell me if the patient qualifies or not to go to a SNF. You, as a doctor, don't make the determination. You suggest it, but the physical therapist is the one that basically says yes or no. And yes, it's not that they have more hierarchy than you, but this is the way that insurances pay for this. And if you don't have insurance, you cannot get to a SNF. So the steps to follow are: you consider the need for this patient to go to a SNF. You call a physical therapist who does an evaluation, and the evaluation is positive for a SNF. For example, what could be needed? This patient has been in the hospital for 20 days, and he's not able to stand. He's not able to really walk safely, and he won't be safe at home. So for continuation of physical therapy, you need to send this patient to a skilled nursing facility. Or maybe this patient has ESBL, E. coli, so this patient went to a local SNF for IV antibiotics, because this is one of the things they can do. So these patients at the SNF, they are not long-term. They're staying there for as long as the insurance will pay for it. And usually this is limited, maybe 1 month, maybe 2 months. But while they are there, they can also get infections, the same infections that you get living anywhere. You can get a cold, you can get a hip fracture from falling, because the nurses, even if they're watching you, it's not constant. And so when something happens, when the patient develops a fever or gets very short of breath from, aspiration, the nurse at the local at the SNF says this patient needs to be transferred to the emergency department. So there you get a patient that you present as, this is a 75-year-old male patient who was transferred from a local SNF where he has been residing after being discharged from the hospital for a stroke 2 weeks ago. And he was transferred with a chief complaint of fever, cough, and shortness of breath for the last 3 days. And you continue with your HMP. Sorry. Next one in this group will be subacute care facilities. What are the subacute care facilities? The difference is not big compared to a skilled nursing facility. Only that subacute care have more nurses per patient, and they have more intensity of treatment. They can do a little more because they have more nurses. They can dedicate more time to each patient. And usually the patients that are in a subacute level are patients that are stable. They are stable, but they are very stable, but they are still complicated. For example, a patient that has chronic respiratory failure and has a tracheostomy, and was tracheostomy, a G-tube, a GJ tube, needs constant respiratory treatments, is on pain management. So these patients living at a subacute care facility, they have that special need. Usually it's mainly ventilator dependency. So these subacute care facilities are licensed to have nurses and respiratory therapists that will manage ventilation machines. But these patients have to be stable. And because these patients are on a ventilator, they can get what? Ventilator-associated pneumonia. Because these patients have a chronic Foley catheter, they can get indwelling Foley catheter causing UTI, or they can get C. diff. So these patients, when this happens, because it's something very acute, it's something that needs further studies, these patients get transferred to the ER. So there you go, a new subset of patients. While this is a very high level, because you're dealing with ventilators, you need to adjust things, at these facilities, at the subacute facilities, there is a doctor visiting the facility, but they don't stay there long term. They don't stay there all day. They go, see their patients, and leave. If something happens, the nurses will call them. See, this is good, high level, but it's not the highest. The highest is long-term acute care facility. Long-term acute care facility are recognized to be a step down from a hospital ICU. It's even higher to the hospital telemetry unit. This LTAC, or long-term acute care facility, have ability to manage ventilators, G-tubes, chronic Foley catheters, chronic pain management, IV pain management. They have more nurses per patient. They have more respiratory therapy per patient. They are considered a high level. They get paid very well for the amount of work that they have to do. And in these facilities, you have doctors, residents, students going there because these patients are still in need of active acute care, which is complicated, but is uncomplicated. And I don't know if this is something easy to understand, but I'm going to try to say, for example, let's say you have a patient that was in the ICU for septic shock due to, well, let's say a patient which is paraplegic on a ventilator machine who was transferred to the ER or the hospital for septic shock due to C. diff colitis. At the hospital, we fixed the septic shock. We started him on oral vancomycin. He remains on his ventilator, which is chronic. He remains getting G-tube feedings. But we haven't been able to really decrease the amount of bowel movements that he has a day. He still has like 6-8 bowel movements a day. He's stable, but he has 6-8 bowel movements a day. His white blood cell count is normal, creatinine levels are normal, but he still requires a lot of work. So this patient, instead of going to a local SNF, he will go to either to the subacute or to the LTAC. Same for a patient who is paraplegic and has a large decubitus ulcer infected. He gets 1 or 2 debridements at the hospital, gets antibiotics, the infection goes down, and everything is started, but he needs daily debridements. The skilled nursing facility is not going to do daily debridements. The subacute care may do it, but more likely this patient will have to transition to the LTAC first before going to subacute. So the order where patients go around are first, after the hospital, if they were in an ICU bed, they will go to an LTAC. If they were unable to be transferred to telemetry, they go to an LTAC if they need constant intensive care. From the LTAC, they will transition to the subacute care if there's a need. And from the subacute care, they will transition to the skilled nursing facility. Or it may be a patient that goes from telemetry in inpatient hospital to a skilled nursing facility. From a skilled nursing facility, this patient may go to custodial care. And so these are some of the levels that we have to take care at the hospital. It's important that you identify them as where they come from, because we are going to ask you. This changes a lot of things. So that's all I wanted to talk to you about today. We'll see you for another video.